Okay, let's unpack this. We're doing a deep dive today into a really important area, chickenpox exposure in at-risk groups. Yeah, and the material we're drawing from, it's specifically from revision notes, the kind designed to, cut through the noise and give you the high-yield stuff fast. So our mission today is basically to walk through these notes together, pull out those absolutely crucial bits of info, and really help make them stick for you.
And it's so vital we do that because chickenpox, the varicella-zoster virus, it's just incredibly contagious. And while, sure, for lots of people it's mild, for certain groups, exposure can be really serious, lead to severe complications. So knowing how to manage that exposure risk is, well, it's essential.
Absolutely. So let's start right at the beginning. When we say chickenpox exposure, what exactly are we talking about? Like fundamental?
Simply put, it just means contact with someone who's actively infected with the varicella-zoster virus, VZV. And that contact, it usually happens through direct interaction with respiratory secretions.
Coughing, sneezing, that sort of thing?
Exactly. Or contact with the actual fluid from the chickenpox blisters. It's notoriously easy to catch if you don't have immunity.
Right. Yeah, that explains why it can just rip through places sometimes. Okay, so the virus itself is VZV, or herpes virus. How does it actually, get around? How does it make the jump?
Well, the primary route is those respiratory droplets. When someone infected coughs or sneezes, they linger in the air or land on surfaces.
Yeah.
But direct contact with the blister fluid, that's definitely another key way it transmits. And here's the really crucial part for understanding exposure. The person is infectious starting a few days before they even get the rash.
Wow, before they even know they have it.
Yeah, exactly. And they stay infectious until all those blisters have completely crusted over. That pre-rash infectious window is a huge factor in why it spreads so effectively. It's hard to contain.
That hidden phase, yeah, that's critical. Really highlights why managing exposure is so tricky. Yeah. Okay, so thinking about who gets infected after exposure, who really needs to be careful, who's considered higher risk.
Right. So several things increase your risk. Number one, obviously, is being in close contact with someone who's infected. Makes sense. Then being in crowded environments. Think schools, busy households, places like that. It just ups the chance of running into the virus.
Okay.
But probably the biggest factor, the most important one from the notes here, is a lack of immunity to VZV itself.
And lack of immunity means what exactly?
It means you haven't had chickenpox before. Or you haven't had the chickenpox vaccine. Basically, your immune system hasn't learned how to fight off this specific virus yet. No pre-existing defenses.
Got it. So if your body hasn't seen it before, it's vulnerable. Okay, let's go a bit deeper then. Once the virus actually gets in, what's the journey? What's happening inside the body, pathophysiology-wise?
So typically, VZV enters through the respiratory tract. You breathe it in.
Right.
Then it starts to replicate, make copies of itself right there in the mucous membranes, linings of your nose, throat. From there, it spreads into the nearby lymph nodes, little immune system hubs, and then, this is key, it gets into the bloodstream. This is called the viremic phase. The virus is circulating all through your body.
Okay, so it's traveling everywhere.
Exactly. And it's the circulation that allows it to reach the skin cells, infect them. And that's what leads to the characteristic chickenpox rash. The body's immune response kicks in, causing inflammation in the skin, and you get those, itchy, fluid-filled blisters. But what's really fascinating and definitely high yield from these notes is what happens after. Even when you recover, the VZV doesn't actually leave your body.
Ah.
No, it establishes latency. It basically goes dormant, hides out in nerve clusters, sensory ganglia.
Wow.
Yeah. And it can stay there for years, decades even. And then later in life, it can reactivate. That's what causes shingles. So chickenpox isn't always just a one-off childhood illness. It has this long-term potential. That's really key context for at-risk people.
That latency and shingles link is, yeah, that's a huge point. Definitely memorable. Okay, so thinking about the rash. Sometimes rashes can look alike, right? What else might you mistake for chickenpox? What are the differentials?
That's a good point. While the chickenpox rash is often quite distinctive, with those different stages all present at once, there are other things that could cause confusion. You might think about other viral exanthems. That's just a fancy term for widespread viral rashes. Things like measles or rubella, though they usually look different.
Okay.
And sometimes certain drug reactions can cause a rash that maybe initially looks a bit like it, but usually you differentiate based on the full picture, the patient's history, how the rash looks and where it is, other symptoms. Diagnosis is mostly clinical.
Based on what you see.
Yeah, primarily. Lab tests aren't routine. They're really only needed in, specific situations. Atypical cases, maybe someone immunocompromised where you need absolute certainty, then you might do tests.
Gotcha. Okay, shifting gears slightly. How common is this, epidemiology-wise? Especially thinking about the UK context of these notes. Who usually gets it?
Well, historically, it's been super common, a standard childhood illness, really, in the UK and worldwide. We have seen a decrease since the chickenpox vaccine was introduced in some places, but it's definitely still around. The most common age group is typically young kids, sort of 1 to 9 years old, and this is important, people of any age can get it if they aren't immune. Adults, teenagers, everyone's susceptible.
Right, okay. So let's paint that picture then. Someone gets chickenpox after being exposed. What does it actually look like? What does it feel like? The clinical features.
Okay, the rash is the absolute hallmark, and it goes through stages. Usually starts as small red spots, papules.
Really.
Then, quite quickly, they turn into these clear, fluid-filled blisters, like little water droplets. Those are vesicles. Then the fluid might get cloudy, yellowish, they become pustules, and finally they dry up, form a crust or scab, and eventually heal. The key thing is you often see lesions in all these different stages at the same time, on the same person.
Okay. Different stages simultaneously. Where does the rash usually show up?
It typically starts on the face, chest, and back, the trunk. Then it spreads outwards to the arms, legs, can be pretty much anywhere eventually. And alongside the rash, you usually get other symptoms. Fever is common, feeling really tired, fatigue, headache, maybe loss of appetite. And of course, the itching, intense itching. Pruritus is the medical term.
That combination sounds pretty miserable. The evolving rash, the fever, the itch. Okay. Now, you mentioned diagnosis is mainly clinical. Do you ever need tests to confirm?
For a typical case, no, usually not. If it looks like chickenpox, smells like chickenpox,
No.
The clinical picture is usually enough.
Makes sense.
Routine lab tests just aren't necessary for a straightforward diagnosis in a healthy child, for example. But, like we touched on, if things look a bit unusual, or if the patient is immunocompromised, then yes, confirmation might be important. In those cases, you might use tests like viral culture from a lesion or PCR to actually detect the VZV virus. But again, that's for specific circumstances.
Okay. Crystal clear. So we know what it is, how it spreads, who's at risk, what it does inside, what it looks like, how you diagnose it.
Yeah.
Let's get to the what do you do about it part, management.
Yeah.
Especially focusing on those at-risk groups.
Right. So the foundation is supportive care for anyone with chickenpox. Managing the fever, using things to soothe, the itching calamine lotion, cool baths, stuff like that. And good hygiene is key, too, to stop secondary bacterial infections and limit spread.
Okay, basics first.
And prevention is huge. So vaccination for people who aren't immune is a really important preventative strategy. Now, for treating an active infection, this is where it gets targeted. Antiviral medications, like acyclovir, they aren't typically used for healthy kids with chickenpox. They are generally reserved for people at higher risk of severe disease. That includes pregnant women who get chickenpox, newborns, and definitely individuals who are immunocompromised. For them, antivirals can really make a difference.
So antivirals for the high-risk patients with chickenpox. What about after exposure for those high-risk people?
Yes. That's where something called VZIG comes in. Varicella-zoster immunoglobulin. This is post-exposure prophylaxis.
Okay, VZIG. What is it and who gets it?
It's basically a shot containing antibodies against VZV. It gives passive immunity, and it's given after a significant exposure but before illness develops, specifically to individuals who meet certain criteria. They need to have had a significant exposure. They need to have a clinical condition that puts them at high risk for severe chickenpox, like being severely immunosuppressed, maybe certain newborns whose mothers got chickenpox right around delivery time, or susceptible pregnant women.
Susceptible meaning no immunity.
Exactly, and that's the third criterion. They must have no detectable antibodies to VZV themselves, no proof of immunity. If they meet all these, VZIG can be given to try and prevent the infection, or at least make it much less severe. It's a really targeted intervention based on that risk profile. Very high-yield concept.
That is really key. That tailored approach, antivirals for some, VZIG for others after exposure, based entirely on their risk. Okay, last piece then. Prognosis and complications. What's the usual outcome and what are the dangers, especially for these vulnerable groups?
So for most healthy children and adults, the prognosis is generally very good. Chickenpox is typically self-limiting. It runs its course in, a couple of weeks, and most people recover completely without any lasting problems.
That's good news for most.
It is. However, the potential for complications is definitely real, and it's much higher in those specific high-risk populations we keep mentioning. Infants, adults in general compared to kids, pregnant women, and anyone immunocompromised.
What kind of complications are we talking about?
Serious ones, unfortunately. Bacterial infections of the skin lesions are quite common if it gets scratched a lot. Pneumonia, especially varicella pneumonia in adults, can be severe.
Huh.
You can also get encephalitis, which is inflammation of the brain, hepatitis, inflammation of the liver. These aren't common overall, but the risk is significantly elevated in those vulnerable groups, and they can be life-threatening.
Wow, okay. Serious stuff.
Absolutely.
Yeah.
Which is why close monitoring and getting prompt medical attention is so crucial for anyone in those high-risk categories if they get exposed or start developing symptoms. Understanding these potential severe outcomes really underscores why those targeted management strategies like antivirals and VZIG are so important.
Okay. Phew. So we've really gone through these revision notes piece by piece, covered the virus, the spread, who's most vulnerable, what it looks like, diagnosis, and crucially, that tailored management based on risk, right through to outcomes and those serious potential complications.
Exactly. The goal was really to pull out those high-yield nuggets for you. The key things to remember about chickenpox exposure in at-risk groups: understanding the transmission, being able to recognize it, knowing who is at higher risk for bad outcomes, and crucially, knowing about the specific interventions like antivirals and VZIG for those specific people. That's the core information you need. And, thinking about all this, especially that latency point, it does raise an interesting question, doesn't it? Given that VZV hangs around in the body for life after chickenpox, how might that hidden latent virus continue to shape someone's health decisions or even wider public health strategies, year or decades later, long after that initial rash is just a memory, something to ponder?
That's a great thought to leave things on. And that wraps up our deep dive into chickenpox exposure in at-risk groups. Hopefully, walking through the notes this way has helped solidify those key points for you. If you are deep in MSRA revision mode right now and found this useful, there are definitely more resources out there that could help you out. You can check out PassThem.MSRA.com for comprehensive MSRA revision materials. And for some excellent free MSRA resources, definitely visit freemsra.com. Thanks so much for joining us for this deep dive. We'll catch you on the next one.